Hello, I'm Rahul, a junior doctor in the UK, and my aim is that by the end of this video you'll begin to love reading ECGs. This video is different from others in that I'll explain why we get certain findings and start with first principles where possible. For example, why do we get hyperacute T waves in the early stages of a STEMI? And why do we get ST depression in subendocardial ischemia, but in epicardial ischemia we get ST elevation? And what actually are pathological Q waves? We'll tie everything together at the end with an interesting ECG. Now this works best as a semi-interactive session, so please do attempt any questions. Now everything revolves around the following system, so I want you to remember these 5 steps. Rate, rhythm, axis, hypertrophy and infarction. That's rate, rhythm, axis, hypertrophy and infarction. But before there's a few other things to cover. So what actually is depolarisation, and why is that useful for us to understand the ECG? So the heart has many cells and these constantly go from negative to positive, and this is depolarisation. The depolarisation travels in a specific direction, so in this case it's travelling this way. Now I want you to imagine leads as like a speed camera. If it's towards the lead, it's positive. If it's away, it's negative. So in this case, the wave of depolarisation is clearly going towards the lead, so therefore we get a positive wave. Now if it were to go the opposite direction, we'd get a wave that looks something like this, a negative wave. Now we have 3 limb leads, so we have lead 1, lead 2 and lead 3. Lead 1 is best remembered as pointing towards your left. Lead 2 points towards your left hip. Lead 3 points towards your right hip. We also have augmented leads, which are effectively rehashed versions of lead 1, lead 2 and lead 3. AVL points towards your left shoulder, AVR towards your right, AVF points towards your feet. We can combine these to get our 6 leads. And these can be further classified based on their location. So AVL and 1 are on the lateral side, so these are referred to as lateral leads. 2, 3 and AVF are inferior, so these are referred to as our inferior leads. Now we also have 6 of the chest leads. So these are classified based on their location. So V1 and V2 are septal, V3 and V4 are anterior, and V5 and V6 are lateral. And together we have 6 chest leads or precordial leads and 6 limb leads, and together these form the 12 lead ECG. So now let's move on to foci. Now foci can generate impulses just like the SA node, and they're useful because let's say the SA node is taken out, then one of these can fire and take over the role of the SA node. And as you can see, there's 3 different categories of them. So over here we have the atrial foci. Here we have junctional, which just means around the AV node, and here we have ventricular foci. Now these foci demonstrate something interesting called overdrive suppression. Now you don't want them all to fire at the same time, so there's sort of a hierarchy. So at the top we have the SA node, which inhibits all the other foci. The atrial foci inhibit the junctional, and the junctional inhibit the ventricular. So if the SA node were to fail, one of these atrial ones would take over. If that fails, the junctional. If that fails, then the ventricular one takes over. Now occasionally you have foci that effectively don't follow this hierarchy. And so either it can become irritable and fire a one-off beat, or it can become parasystolic like this one, and effectively just fires off on its own accord. So let's say the SA node is still working, you therefore then have 2 separate pacemakers. Now it's also important to know a bit about the autonomic nervous system. So the parasympathetic nervous system, decreases SA node. So the SA node would fire less. Decreases conduction through the AV node. It decreases contractility and it makes the foci less irritable. The sympathetic system, on the other hand, does the opposite. So the SA node will fire more. Conduction through the AV node will be quicker. The heart will contract harder, and the foci become more irritable. And a good clinical correlation is sinus arrhythmia. So with sinus arrhythmia, we know inspiration increases sympathetic activity, which you can see in green here. So you get periods of faster rates given this irregular rhythm. Now you might know that an irregular rhythm can indicate AF, but because we've got P waves and all the P waves are identical, as they're probably originated from the SA node, this is a sinus arrhythmia. Okay, so now let's move on to rate. So tachycardia generally is more than 100 beats a minute. Flutter is 250 to 350, and fibrillation 350 to 450. Now it's important to know how to work out the rate. So one of these small squares is worth 40 milliseconds. There are 5 of these small squares in a box, so therefore a large box is 200 milliseconds. Now to calculate the rate, we take 2 of the same point. So we take the Q and the Q here, and we count the number of big boxes between them. So we have 1, 2, 3, 4, 5, and we do 300 over the number of boxes. So we have 300 over 5, which is 60 beats per minute. Okay, so that's the rate. This is 60 beats per minute. Okay, so now let's move on to rhythm. There's a couple of important things you need to know how to calculate. The first is a PR interval, which starts at the beginning of the P wave and goes to the Q. So really it should probably be called the PQ, but we call it the PR interval. Okay, now the PR interval should be between 120 and 200 milliseconds. And it represents the start of atrial depolarization to ventricular polarization. It represents the delay. Now, if it's more than 200 milliseconds, you know that there's a delay above or at the level of the AV node. So above 200 milliseconds, you know there's a problem in the circled region. If it's less than 120, that's a bit too quick, so that should alert you to the possibility of an accessory pathway. It might be that the impulse is following a separate pathway, so for example over here. Next we'll move on to the QRS interval. So the QRS interval is measured from the start of the Q wave to where the S wave joins the ST segment. Now generally this is between 80 and 100 milliseconds. It's pathological if it's more than 120. Now if it is more than 120, you know that the problem lies below the AV node. So if you get any QRSs that are more than 120 milliseconds wide, you should strongly suspect bundle branch block. Right, so now we move on to the QT interval. So the QT interval is measured from the Q, from the start of the Q wave to the end of the T wave. Now it's very important to measure this accurately. So you draw a line at the end of the Q wave, the end of the T wave, where the slope is maximal, and you see where that intersects with the isoelectric line. So you'd measure from here to here. Okay, and that's your QT. Now the QT does vary with rate, and so you can use a formula to work out the QTC. Now generally the QTC should be less than 450. If it's more than 500, then you really should look at causes as to why it's prolonged, and often it can be due to drugs. Now some of you might have spotted that there's a wave here, a U wave. Now to understand what this is, you have to know that the T wave represents ventricular repolarization. And the Purkinje fibers, take a lot longer to repolarize. So this is just delayed repolarization of the Purkinje fibers. Now let's discuss some AV blocks. So we know that the PR interval should be less than 200 milliseconds. Specifically, it should be between 120 and 200. Now, if it's greater than if it's greater than 200, we have an AV block. And there are 3 types. And I think it's easiest to cover first degree and third degree. So with a first degree AV block, essentially you have a PR interval that's constant, and you have no dropped QRSs. Now this is often seen in athletes with high vagotone. With third degree AV block, you have AV dissociation. So if you have a look, these P waves are fairly regular. You've got one here, one here, one here. You also have a P wave here, and you can see that because we'd expect a P wave here, but also that the T wave is a little too tall. So if you have a tall T wave, suspect that there might be a P wave in there if it's tall compared to the rest. The QRSs we can clearly see are regular. So effectively we've got P waves firing off at their own rate and QRSs, so we've got 2 separate rhythms. So this is known as a third degree AV block. Okay, so now let's move on to second degree AV block. Now with second degree AV block we have 2 types. We have Mobitz 1 and Mobitz 2. Now Mobitz 1 is a problem above the AV node, and it leads to PR increasing and then a QRS drop. So this first one is a Mobitz type 1. Okay, and a Mobitz type 2 is below the AV node. So it's generally a problem with the Purkinje system, and the PR interval is constant, but you get some P waves which are blocked. So it appears as a constant PR with some QRSs that are dropped. So this is a Mobitz 2. So now you know this information, let's see if you can work out what this rhythm is. So I'd like to pause the video and have a go. Okay, so if you look carefully, you can see that the PR intervals does prolong slightly, and then you've got a P wave that drops. This one is more clear, you have a short PR, longer, and then this P wave comes and it's dropped. So this is a Mobitz 1 pattern. However, if you didn't know whether it's a Mobitz 1 or a Mobitz 2, you could increase parasympathetic drive. So get the patient to do a vagal maneuver. And because Mobitz 1 is a problem with the AV node, this leads to a prolongation of the rhythm. So it goes from beat, beat, block to 3 and then a block. Mobitz 2, on the other hand, you'd have no response because it's a problem with the His-Purkinje system. Okay, now let's discuss bundle branch block. Remember that the QRS should be less than 120 milliseconds. If the QRS is greater than 120, then you should suspect a bundle branch block. Remember, QRS, if it's prolonged, it indicates a problem below the AV node, whereas a PR interval, if that's prolonged, it suggests a problem at the AV node or above. Okay, so let's start off with the right bundle branch block. So the first stage is the SA node fires. So SA over here fires and we get a P wave. This is all perfectly normal. We get a P wave in V1 and a P wave in V2. Now, bundle branch block, the easiest way to learn it is to have a look at V1 and V6. They're almost at extreme ends of the heart. So the V6 looks from the left and V1 looks from the right side of the heart. Okay, so now we go into the septal depolarization. And if you have a look, we have an R wave in V1 and a Q wave in V6. And you might wonder why. Well, if you look closely over here, the left bundle is the only one that has terminal fibers in the septum. So therefore the depolarization spreads from left to right. Since V6 is over here, it sees a wave of depolarization going away from it. So therefore we get a Q. Whereas V1 is over here and it sees a wave of depolarization towards it. So you get a small r. So remember, septal depolarization is away from the left and towards the right. So now before we go into this, everything so far has been normal. This is normal, this is normal. Also, something else to note is all the lateral leads should generally have a small Q wave. Sometimes they're not present, but it's normal if they are, because remember the initial wave of depolarization is away from them in the septum. So now we move on to the problem. So the right bundle branch is blocked, so it's not going to conduct anything. So the left depolarizes as normal, so effectively you have a wave of depolarization now going towards the left. So if V6 is over here, it sees a wave of depolarization towards it, so therefore you get a large R in V6. V1 is over here, and it sees the wave going away from it, so therefore it gets an S. Okay, so V1, the wave goes away, so it gets an S. V6, it's towards it, so it gets an R. So now, eventually the right ventricle does depolarize. Okay, even though the bundle branch was blocked, muscle-to-muscle depolarization happens. It's slow, but it happens a bit late, and it happens a bit later, but it does eventually happen. So now we have depolarization in this direction. So if V1 is here, now the depolarization is towards it, so it records an R. Okay, and V6 is over here, and it sees depolarization away, so therefore you get an S. The S is a bit wide to reflect how long it takes, because remember, muscle-to-muscle depolarization is very slow. So in summary, in V1 you have a small r, you have an S, and then you have an R prime. And here, and in V6 you have a small q and you have an R. So V1 you have an R-S-R pattern, and in V6 you have an RS pattern. Now let's look at the other chest leads. So as you can see, the right-sided, so these are the right-sided leads, V1 to V3, you have the RSR pattern and the RSR. And in the left-sided leads over here, you have the deep slurred S wave and you have the R, so you have an RS pattern. Now V4 to V6 they're lateral, specifically V5, V6 are lateral leads, so therefore we'd also expect 1 and AVL to have the same findings. So to summarize, we have a QRS of more than 120 milliseconds. We have an RSR pattern in V1, and we have deep slurred S waves in V5, V6, 1 and AVL. Now a left bundle branch block, essentially if you understand how a right works, the left is the same but the opposite. So the first criteria is QRS more than 120 milliseconds. Second criteria is you have a broad or monophasic R in V6. Sometimes it can be notched like it is here. And 3, you have deep S waves in V1. And of course, the broad monophasic R wave that we see in V5, V6 will also be seen in 1 and AVL because they're also lateral leads. Sometimes the left bundle is incompletely blocked. So it has 2 fascicles. So you have the anterior fascicle and you have the posterior. And often only one is blocked. So we'll discuss left anterior fascicular block first. So the anterior one, the anterior left anterior fascicle supplies the superior surface of the left ventricle. So if it's blocked, we get the P wave as normal. Okay, but then the right ventricle activates, but we only have the inferior aspect of the left ventricle. So therefore depolarization sort of goes in this direction. So that's why we get an R in lead 3 and we get a Q in lead 1. Eventually, just like the bundle branch blocks, the superior aspect of the ventricle does depolarize. And now the depolarization is in this direction, which is towards lead 1. So therefore we get a large R. Since it's away from lead 3, we get a large deep S. Now this can be easily remembered as Q1 S3. Now I know we've not covered left posterior fascicular block, but that's just the opposite. So that's S1 Q3. Now anterior, remember, is first and Q is before S in the alphabet. So that's how I remember. Left anterior fascicular block is Q1 S3. So let's have a look at the other leads. So if you remember, I said you'd get a Q in lead 1 and you'd get a deep S in lead 3, which we do. And since AVL is also a lateral lead, we'll get the same finding. And since AVF and lead 2 are inferior, we'll also get the same findings as lead 3, so we get deep S waves. Now one other thing to note is if you see the S wave is deeper in lead 3, which is typical for a left anterior fascicular block. Now I know we've not covered axis yet, but an important clue is if the axis is greater than negative 45 degrees, then you should be concerned for left anterior fascicular block. Left posterior fascicular block is essentially the same but the opposite. So we have an S in lead 1 and we have a Q in lead 3. And again, these findings are reciprocated in the same leads. So the inferior leads all have small Q waves and the lateral leads have deep S waves. It's also worth remembering that left posterior fascicular block has right axis deviation, whereas left anterior fascicular block is left axis deviation. So left posterior, whereas left axis deviation is left anterior block. Left anterior fascicular block. Okay, so now let's discuss escape rhythms. Well, before we do that, I want to quickly just remember the foci and the overdrive suppression. So remember we have the SA node, and then we have the atrial foci, which suppress the junctional, and below that you have the ventricular foci. Now, generally what should happen is if the SA node is taken out, the atrial one takes over. If the atrial is taken out, the junctional one takes over. Now, each of these has their own intrinsic rate. So the atrial one is 60 to 80 beats per minute. The junctional is 40 to 60. And the ventricular is 20 to 40. Now, these are just the inherent rates. They can be quicker, they can be slower. Now, it's also worth remembering that sometimes a foci takes over not because, for example, say the SA node has stopped firing completely. Sometimes the SA node fires very slowly. So let's say the SA node starts firing at 10 beats per minute. In this case, the atrial one is faster. So it's not suppressed anymore. So it will now beat at 60 to 80 beats a minute. So let's have a look at a few examples. So in the first one, you can clearly see that there's quite a quick rhythm here, and then it slows down sort of on this blue side. And you can see here there's probably some sort of an SA node pause, okay, and a slower rhythm has resumed. So if we work out the rate on this one, so the rate is 1, 2, 3, 4, so 300 by 4 is 75 beats per minute, which is in the 60 to 80 beats a minute range of an atrial escape rhythm. So therefore this is an atrial escape rhythm. Now something else I want to draw your attention to is the P waves. So if you have a look at the shape of the P waves, or the morphology, you can see that the green ones are very different to the blue ones, which indicates that the P waves are originating from different places, which further adds evidence to it being an atrial escape rhythm. Now if we have a look at the next one and we calculate the rate, we have 1, 2, 3, 4, 5, 6, 7. 300 by 7 is about 42 beats per minute. Okay, and a junctional escape rhythm intrinsically is between 40 and 60, so this just about fits. We also see that there's no P waves, which is expected. However, these are actually retrograde P waves. So if you imagine the AV node is here, the SA is here, you have the His-Purkinje system, say the junctional foci is here. It will activate the atria in a retrograde fashion as well as activating the ventricles, because it's activating in the opposite direction to how the atria normally activate. Instead of getting an upright P wave, you get an inverted one, which explains these. It also explains why it's after the QRS. The ventricles are activating first and then the atria. Okay, so let's move on to the next one. So this one, the first thing that should strike you is just how wide these are. So if you have a look, so this is there to there, I would say that's probably about, so it's 1, 2, 3, half there and half there, so we would say 4 squares. So 4 times 40, 160 milliseconds. Now anytime you have a wide QRS, you should be thinking it's below the AV node, so immediately you should suspect that it's a ventricular escape rhythm. Okay. Secondly, if we work out the rate, so we have 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, so therefore we have 11 boxes. 300 by 11 is 27. So therefore this fits in with a ventricular escape rhythm of 20 to 40. Remember, the escape rhythms can be quicker and slower, but the intrinsic rate of a ventricular escape rhythm is 20 to 40. So this is a ventricular escape. Now coincidentally, this is also a good example of a third-degree AV block. You can see P waves, and actually the P waves are fairly regular. So you can see the P waves have their own regular rate, and so do these. So therefore this is a third-degree AV block, and what's probably happened is these P waves are not conducting at all, so therefore a ventricular foci has taken over pacing. Okay, so now let's have a look at escape beats. Escape beats are different in that usually they're one-off beats rather than a continuous rhythm. Now it's important to understand why we get the occasional escape beat. So here we have a diagram with the foci, and we're going to categorize them into two camps this time. So we have the atrial ones and the junctional ones, and then separately we have the ventricular ones. And while there is a lot of overlap between them, they're generally irritated by different things. So the atrial and the junctional foci are irritated by things like epinephrine, caffeine, beta-1 agonists, and sympathetic stimulation. The ventricular ones are irritated more by metabolic conditions such as hypoxia and hypokalemia. Also stretch, but I want you to remember hypoxia and hypokalemia in particular. Now, one interesting clinical correlation is hypothyroidism. So why does hypothyroidism increase the risk of the foci being irritable? So if you remember, someone with hypothyroidism is generally tachycardic. Okay, and the reason why they're tachycardic is that the thyroid hormones upregulate the beta receptors. And if you think about it, it's the reason why we give beta blockers in patients with hypothyroidism. And of course, sympathetic stimulation increases the risk of the foci being irritable. So that's why hypothyroidism increases foci irritability. But the key takeaway I want you to remember is atrial and junctional is sympathetic stimulation and drugs. Ventricular foci are irritated by hypoxia and hypokalemia. Okay, so let's have a look at what premature beat this is. So if we have a look, we can clearly see that this is premature. Okay. Now, if we have a look, we can see that there are P waves before the QRSs, and the P wave before this one is inverted. Now, this suggests that the P wave is originating from somewhere else. So this is a premature atrial complex. So it's an ectopic foci that's fired off. Now, something else to note is that when a PAC arrives, it resets the SA node. So you can see that the SA node was firing 1, 2, 3, 4 every 4 squares. Okay, and when this arrives, it resets the SA node. So you end up with this pause, which we call the compensatory pause. Compensatory pause. And if you have a look, you've got 1, 2, 3, 4. So therefore the SA node has been reset because it's now fired after 4 squares. Now let's have a look at this rhythm. If you'd like to pause the video and have a go at what this is, please do so. Okay, so the first thing that should come out at you is that we have a P wave here. But the P wave's not led to anything, and the reason why is after the ventricles contract, you have a refractory period. Now this has effectively come on the T wave, and so it's arrived when the ventricles are refractory, so therefore it can't be conducted. So this is a non-conducted premature atrial complex or contraction. This does still, however, reset the SA node, and you can see this because the SA node was firing 1, 2, 3, 4, 5. Every 5 squares here, and here if we have a look, we go 1, 2, 3, 4, 5. It fired again after 5. So therefore, even though the premature atrial contraction didn't lead to a QRS and it wasn't conducted, it still reset the SA node. This is a premature junctional complex. So as you can see, there's no clear P wave before it. It is premature, so we know it's a premature beat. Also, if we have a look, it's narrow, so therefore it must be above the AV node, at or above the AV node. So it must be atrial or junctional. And we don't see any clear P waves, so therefore this is less likely to be atrial, and this is a junctional escape rhythm. Now, junctional rhythms, a premature junctional complex still resets the SA node, so you still get this compensatory pause. Okay, so the next one, this one looks bizarre. So again, the first thing that should strike you is that there's a very wide QRS complex. Therefore, this originates below the AV node, and this is likely to be a ventricular in origin. So this is a premature ventricular complex or contraction. Now this also leads to a compensatory pause, but it's not really compensatory. What happens is the SA node isn't reset. It's not reset. Okay, what happens is the SA node fires. So for example, the SA node was firing every 1, 2, 3, 4. So therefore the SA node will have fired 1, 2, 3, 4. So there would have been a P wave that arrived somewhere here. But it wasn't conducted because it arrived when the ventricles were undergoing contraction. So therefore the ventricles here were refractory. So the SA node fires again, 1, 2, 3, 4, and we see a P wave there. So therefore we still get a compensatory pause after the premature ventricular contraction, but it's not due to the SA node being reset. Now, quick question, why is more than 5 in a minute a bad sign? So if you remember to the couple slides back, 2 important causes are hypoxia and hypokalemia. So generally, if you see 1 or 2 on an ECG, it's not too concerning. But if you see more than 5, that's a bad sign, and you really should be concerned about these 2 things in particular. Okay, so now I'd like you to have a go. So which premature beat is this? So if we have a look, this is it's slightly enlarged slightly wide compared to the other QRSs, but it's still quite a narrow QRS. So it's still likely to be atrial or junctional. Okay, we see a P wave, and this P wave is a different morphology to the others. So it's originating from somewhere else. So therefore this is likely to be a premature atrial complex. Now you might be wondering, why is the QRS wider than the others? So when the ventricles contract, so they enter a refractory period. Okay, and the bundles recover at different rates. So if the P wave arrives at the right time, then it can find one bundle branch still refractory while one can be conducted. So we end up with a slightly wide QRS complex, and we call this a PAC with aberrant conduction. So it's still a PAC, just a special type. Okay, so now let's move on to SVT and VT. So remember, SVT, supraventricular tachycardia, is above the AV node, at or above the AV node, sorry, and VT is below. Okay, so we'll start off with some tachycardia. So the first one, you can see there's a P wave before each QRS. You can see the QRS is a narrow. Since they're narrow, they're following the normal conduction system, so it must be at or above the AV node. So this can be atrial or junctional. Since there's P waves, this is atrial. Now in this one, again we have a narrow QRS, so therefore this is at or above the AV node. And we don't see any P waves beforehand. So this is less likely to be atrial, more likely to be junctional. Now, these are what we call pseudo S waves. So usually the P waves are upright, especially in 2, 3, and AVF. This is what defines a sinus rhythm, if the P waves are upright in 2, 3, and AVF. Now, since they're inverted, it means that the impulse is going the opposite way, which is expected. So if you have the AV node here, SA here, which has the atria, say the junctional foci is here, it's going to conduct in a retrograde manner. So the atria will contract will depolarize in the opposite way to how they would normally. So instead of an upright P wave, you get an inverted P wave, which looks like an S. It occurs after the QRS complex, because the foci has depolarized the ventricles first before depolarizing the atria. Okay, so now we're going to discuss AVNRT and AVRT, but before that we need to know how the AV node works. Often there's a dual pathway, and this is normal. So one path is fast conduction, so the fast is here in orange and you have the slow here in red. And they're fast in the way they conduct. So usually the fast one comes down, sort of down here, it then conducts to the ventricles, and because the slow one is still up here because it conducts very slowly, the fast one's able to come round and it collides with it and the whole thing resets. So once the fast pathway has completed to the ventricles and collided with the slow pathway, we get a refractory period. Now this is where it gets interesting, because the slow one, even though it conducts slowly, it recovers quite quickly. Whereas the fast one conducts quickly, but it recovers very slowly. So eventually, well, first the slow one recovers, and then the fast one recovers. And by this point, an impulse comes and the whole process starts again. So you have the fast pathway that comes down, depolarized ventricles, it continues to here. The slow one very slowly comes along, it collides, and it resets. And the whole thing goes back here, and the cycle continues. Now in AVNRT we have a premature wave, so maybe a premature atrial complex or contraction that comes along, and it has to come at the perfect time. So during this time the slow pathway is no longer refractory. Remember, the slow one is slow but it recovers really quickly. The fast one is still in the refractory period, so it comes down and works its way down the AV node, and it reaches a point here. And now it can go down into the ventricles, and by the time it gets here it realizes, oh, actually the fast pathway is now no longer refractory, so it can continue up. So it does, and it continues up. And now when it gets here it realizes, oh, actually now it can go to the atria, and it can still go round in a circle. Now you might see that actually the slow pathway is now refractory, but remember that the slow pathway recovers really quickly, so that even this small distance is no problem, because by the time it gets here the slow pathway is now open again. So eventually you get this cycle. So this goes round and around and around, and it depolarizes the atria and it depolarizes the ventricles at the same time. And this leads to an interesting finding on the ECG. So remember, the atria normally, the SA node is up here and it conducts downwards, so you get an upright P wave in 2, 3 AVF. In lead 1 you can get an inverted P wave, or it can be biphasic, usually biphasic. Please keep that in mind. So you get some interesting findings. So in lead 2, where normally it's upright, we get a pseudo S, which is an inverted P wave. Remember, it's occurring after, because the ventricles are first depolarizing, followed by the atria. Sometimes though you don't see the inverted P, it can be hidden within the QRS. In V1 we have a pseudo R. Remember, in V1 it's either biphasic or upside down. So it's now the opposite. Remember, it occurs after the QRS because the atria are depolarizing after the ventricles. So if we recap, okay, so first you get the premature contraction, usually PAC, and it arrives at the right time. So the fast pathway is refractory and the slow pathway is open. Then it gets to this stage and it realizes, oh, actually it can go down and it can still continue around the path, because now by the time it gets here it realizes that the fast pathway is open. it continues round and it realizes, well, actually now it can go up the SA node, and it can still go down the ventricles. Now this is refractory, but by the time it completes this short space of time, by the time it goes this short distance, this slow pathway is open again. So now you get a big circle, and this circuit is referred to as a re-entry circuit, and it activates the ventricles and the atria at the same time. Now you might be wondering, well, during this time, why hasn't an impulse come down the fast pathway yet? Well, if you remember, this premature atrial complex resets the SA node. So effectively, it leaves enough time before the next beat comes for this path to be completed. And once this is done, this will keep going until it's treated. So now let's move on to AVRT. Before we move on to this, there's an interesting thing that I have to mention. So generally with these tachyarrhythmias, there's only three, or really two big ways that they're caused. So they're caused by some sort of irritable foci, or they're caused by a re-entry circuit. Now the re-entry circuits can be micro, so in the AV node, so in there like AVNRT. Now I didn't mention what AVNRT stands for, but if I do, it makes a lot more sense. So AVNRT, if I write here, is atrioventricular nodal re-entry tachycardia. Whereas AVRT, there's no N, because it's a macro circuit. Okay, and it involves an accessory pathway, which you can see here. Now there's two types of AVRT. There's orthodromic and antidromic. So orthodromic etymologically means something like correct road or correct way. And as you can see, it is following the correct way. So the AV node, it's going down, the impulse is going down the AV node, okay, and then it's going up the accessory pathway. This is abnormal, but the rest of it is normal. And because it's going down the normal conduction system, you get a normal narrow QRS. You can sometimes also get inverted P waves if it goes backwards up through the atria. So this is what we call orthodromic. Now this is what we call an antidromic. Okay, and as you can see, it looks very different. These QRSs are wide. So since they're wide, they're not following the normal conduction system. And if you look, they're not. So you have the accessory pathway here. So first it's going down the accessory pathway, and then it's going up to the AV node, which is the opposite of how it should. Now this is very important to recognize, because you must not give these patients AV nodal blockers. So what are AV nodal blockers? The easiest way to remember some of them is A, B, C, D. So you got adenosine, beta blockers, calcium channel blockers, and digoxin. So do not give the patients any of these medications. Why? Let's say you give them this and you wipe out the AV node. The AV node is a very important function. It's when the patient is in AF, it blocks some of the P waves, so the ventricles don't conduct every single P wave. The accessory pathway can't do that. So now if the patient goes into AF, every single P wave is going to be conducted down the accessory pathway, and this is going to lead to a cardiac arrest. So if there's an antidromic AVRT, please don't give AV nodal blocking drugs. Now, once the patient recovers and they're out of their SVT, the AVRT, you can get a pattern like this. Now, this is Wolff Parkinson White. Okay, and the way to identify this is look at the PR interval. Okay, so the PR interval here is very short because there's an accessory pathway. So this bundle of Kent, here there's an accessory pathway. Also, if you have a look at these orange boxes, you can see there's a slurred wave just in front, and we call that a delta wave. So if you see these two things, alert yourself to the possibility that it could be a Wolff Parkinson White. And remember, there's no adenosine, beta blockers, calcium channel blockers, or digoxin. Okay, so ventricular tachycardia. Now this one's quite easy to recognise. You can see it's a tachycardia, rate of 150. There's two boxes there. Okay, you can also see it's quite wide, so it must be ventricular in origin. Now let's move on to flutter, fibrillation, and multifocal atrial tachycardia. One thing I'd like to mention is the differential for an irregular rhythm. So a truly irregular rhythm, not one that sort of looks irregular, a truly irregular one has three causes. So the first one is atrial fibrillation. The second one is a sinus arrhythmia. And the third one is multifocal atrial tachycardia. Now, we will cover all of these, so don't worry too much about remembering them, but as a heads up, atrial fibrillation, generally, there's no P wave. There's no P wave. Baseline sort of just looks like this, or you don't see any of this, and it just looks sort of flat. Sinus arrhythmia, there are P waves, and they look the same. This is important. Multifocal atrial tachycardia, there are P waves, but they look different. So we'll start off with flutter. So with atrial flutter, the first one is an atrial flutter. And lead 2 is the best to see it, because you often get this sawtooth pattern, and you can't find any isoelectric line, so there's no baseline really. And as you can see, the waves are coming at sort of 300 beats a minute, and these T waves are a bit too tall because there's a P wave within them. So this is atrial flutter. This is ventricular flutter. Sorry, this is ventricular flutter. Also, if you have a look, this is narrow, so therefore it must be above the AV node, so it can't be ventricular flutter. This has to be AF. Okay, now ventricular flutter, these are wide, so therefore it's not following the normal conduction system. There's a problem below the AV node, so therefore this is ventricular fibrillation. And it's at a beat of about 300. Also, just to mention, with atrial flutter, it's very common to have a 2-to-1 block. So if you find any rhythm with 150 beats a minute, strongly suspect atrial flutter. So fibrillation. Again, I told you atrial fibrillation has a very erratic rhythm. Sorry, it has an irregular rhythm. If you have a look at these QRSs, they're narrow, so it must be above the AV node. This is therefore atrial fibrillation. We can't really see the P waves. Now, with ventricular fibrillation, again, it looks bizarre, it's wide, so therefore it's below the AV node. So therefore, this is ventricular fibrillation, this is atrial fibrillation. Okay. So, multifocal atrial tachycardia. Now, I told you the way to recognize these is you get an irregular rhythm, but there's a P wave before every QRS, and the P wave looks different. This is because multiple foci are firing. So if you look at this one, this is very different to this, and that's different to this. So you get an irregular rhythm, but there's a P wave before each one, and the P wave looks different. Okay, so the morphologies are different. And this is because of multiple foci firing. So what's the difference between wandering pacemaker and multifocal atrial tachycardia? Multifocal atrial tachycardia, the rate is more than 100 beats per minute. And wandering pacemaker is less than 100. That's the only difference. So now let's move on to axis. Axis is often neglected, but it's very important to learn. Now, this diagram is also important to remember. So we have normal, and normal is defined by these boundaries. So if you have a look, this is 0, and this is 90. Now, this is also where AVL is. Up here, this is negative 30. Now, some people do call this region physiological left axis deviation, but I don't think that's particularly common. So from minus 30 to 90, this is normal axis. Also, it's defined by it being perpendicular to lead 2. So axis, I think it simplifies the ECG. So if you have a look at this heart, the first thing that should strike you is that the right ventricle is very thick. It's hypertrophied. So the wave of depolarization is going to be more towards the right. Remember, axis is just the mean depolarization vector. So in right ventricular hypertrophy, it's going to go towards the right. So axis is towards hypertrophy. Next, it goes away from infarction. So this is silent tissue. This is electrically silent. It's a bit useless. So the vector in this case is going to be towards the right, because the left, there's not much going on there. So axis is towards hypertrophy, and it's away from infarction. There's also one other thing axis helps you with, and that's bundle branch blocks. If the axis is left axis deviation, so if there's left axis deviation in particular more than 45, negative 45, sorry, then suspect left anterior fascicular block. And this should be strongly up your differential diagnosis. If it's right axis deviation, then suspect left posterior fascicular block. Now, this is a lot less common. So look for left posterior fascicular block afterwards. once you consider all the differentials. This is because the anterior fascicle has a single blood supply, so it's affected a lot more, whereas the posterior fascicle has a dual blood supply, so it's affected a lot less. So now let's move on to how to calculate the axis. First thing you need to know is how to determine whether a lead is positive or negative. So if the R is greater than the S, it's positive. So in this case, you can see the R, which is this, is much greater than the S, which is this bit here. So this is positive. This, there is no S wave, this is just an R, so it's definitely positive. Here you can see again, just an S wave, negative. The R is smaller than the S here, so it's negative. Next thing you need to know is you need to know which way the leads face. Now, the most important leads to remember are lead 1, 2 and AVF. These are the most useful to calculate the axis. So let's start off with an example of how to calculate it. But actually, before we do that, you need to understand what this red and this grey sort of stuff is. So if an axis is positive, so for example, lead 1 faces that way. So if it's positive, we know that the axis has to lie in this half, because this half is pointing towards lead 1. If it's negative, it lies in the grey half, because it's going away from lead 1. Similarly, in lead 2, if it's positive, it must be going somewhat in this direction, so it's in this half. If it's negative, it's going that way and it's in this half. Okay, let's use an example now. So lead 1, the R wave is greater than the S. So that's the R, that's the S, that's positive. This again, the R is greater than the S, that's positive. So now I'll draw two circles, one for lead 1. So lead 1 is positive. Since lead 1 goes that way, we know that this half must be where the axis lies. Lead 2 circle. So lead 2, we know lead 2 goes that way. Since lead 2 is positive, it must lie in this side. Okay, now we combine the two together, because the axis has to be where they overlap. So if we combine it, so lead 1 we're going to draw here, and lead 2, shade here, and this is the overlap. If you have a look, the overlap is in the normal region. Now if we have more leads, we could keep doing this and narrow it down further, but this is plenty. So we know that it's normal axis. Next one. So lead 1, R is greater than the S, so therefore this is positive. In lead 2, the R is smaller than the S, so therefore this is negative. Lead 3 is the same. The R is smaller than the S, so therefore it's negative. So now we'll just draw one circle. So lead 1 is positive. Since lead 1 goes that way, okay, it must lie in this half. Okay, lead 2 is negative. So lead 2 usually points this way. So therefore, instead of this side being shaded, it's in this side. So therefore, we'll draw the line of V2, and this time it's on this side. So if we shade it in, we see that this matches this. So therefore, this is left axis deviation. So now I'd like you to have a go. There are more leads than you need here, but I'd like you to pick one. I'd like you to pick two and have a go at calculating the axis. So let's start off by labeling some. So lead 1, this is an R with a deep S, so therefore lead 1 is negative. Lead 2 is equiphasic. It's not positive or negative. And AVF is positive, okay, because the R is greater than the S, okay. So let's calculate it. So let's use lead 1. So lead 1, since it's negative, lead 1 points that way. So therefore, it's going to be in the opposite half. It's going to be in this half. Now AVF points that way. Since AVF is positive, it's going to be in the same half. So therefore, AVF is here. And the overlap is this quarter here. And if we have a look, it's over here, which is right axis deviation. After a while, you won't need to draw these circles, but these just illustrate the point. Now, lead 2 is equiphasic. If it's like this, then it lies perpendicular to the lead. So lead 2 goes down that way. So therefore, it lies either on this side or on this side. And the only way you can tell is by looking at another lead. So by using lead 2, let's just have a go. So by using lead 2, we know that it either lies here or it lies here. Now, let's have a look at AVL. AVL is negative. So therefore, the depolarization is away from the AVL. So therefore, this rules this one out. So therefore, the axis is this. So we know it's right axis deviation. That's an alternative way of thinking about it. I think this is still simpler for most cases. So now let's discuss ventricular hypertrophy and atrial hypertrophy. If you look at this ECG, what's the first thing that strikes you? For me, the QRSs on the right side, right-sided leads over here, are much greater than the left-sided lead, which is the opposite way around how it should be. Remember, the left ventricle is slightly hypertrophied compared to the right, or slightly larger, I should say. Therefore, this should raise suspicions of right ventricular hypertrophy. So let's look at some formal criteria. So in V1, you have either an R greater than S, or you have an R greater than 7 millimeters. Second criteria, in V6, you have an S greater than the R, or you have an S greater than 7 millimeters. And third, you have right axis deviation, usually more than 110 degrees. All of these make sense because right axis deviation, if you think about it, the axis points towards hypertrophy. So now let's have a look to see if our ECG meets these criteria. So in V1, the R is definitely greater than the S. So it definitely meets that. Is the R more than 7 millimeters? We have a look. That's 10. Remember, each large box has 5 millimeters in. So you have 5 here and you have 5 here. So therefore, this is 10. Now let's have a look at V6. In V6, is the S greater than the R? You could make the argument it is, but certainly the S wave does look 7 millimeters. So it probably meets this second criteria. Right axis deviation you can't tell based on just chest leads, but you only need really these first two. This also helps. So this is a right ventricular hypertrophy. Now if we have a look at this one, again this is the opposite to the other one. So you can see that the R waves are much higher in the left-sided leads. Okay, and this is how it should be, but we need to work out whether this is pathological or not. So there's some criteria. So the first one is the R wave in V1 plus the S wave in V5 is greater than or equal to 35 millimeters. The second criteria is AVL greater than 11 millimeters. Now this is not really useful here because we don't have AVL, and also you shouldn't really use it if there's left axis deviation. So not in left axis deviation. Another criteria you can use is if the R waves on any of these chest leads are R or S waves are greater than 25 millimeters. So greater than 25 millimeters in the chest or precordial leads, or greater than 20 millimeters in the limb leads. If we have a look at this ECG, so let's try criteria 1. So V1 we need to have a look at the S wave in V1 and the R wave in V5. I'll rewrite this. So the S wave in V1 plus the R wave in V5. So I wrote that the wrong way around. Okay, so the S wave in V1 is, we have 4 big boxes, and the R wave in V5, okay, we have 1, 2, 3, 4, 5, 6, 7. So we have 7. So 7 plus 4 multiplied by 5 is 55 millimeters, which definitely exceeds the 35. So therefore we probably have left ventricular hypertrophy. Remember, we multiply by 5 over here because one of these big boxes has 5 millimeters. Now you only need one of these criteria. Now the voltage criteria are susceptible to quite a few things. So that one of them is age. So if the patient's under 40, then this 35 millimeter criteria isn't very good, and we often use 45 millimeters. Also, there's a better criteria out there, and if you want to search it, okay, this is a more comprehensive. But even this, it can't diagnose left ventricular hypertrophy. The only way you can do that is with an echo. Also remember the patient's body habitus affects the voltages. So if the patient is particularly large, then you'll often get small voltage ECGs. Okay, now let's move on to atrial enlargement. So I remember this as P pulmonale and P mitrale. Remember the pulmonary is on the right side, so therefore this is right and this is left. Now, if there's multiple leads you can have a look at. There's criteria for V1, but we'll only talk about lead 2 for now. So in lead 2, if the P wave is greater than 2.5 millimeters, you have P pulmonale, so right atrial enlargement. As you can see here, there's 1, 2, 3, so this is 3.5. This definitely meets the criteria. With left atrial enlargement, there's 2 criteria. And you can meet either one. So the first one is you get an M shape, which is why it's called P mitrale. So these peaks, if there's more than 40 milliseconds, which is one small square, you have left atrial enlargement. This is 2 small boxes, so therefore this is 80. This definitely is left atrial enlargement. The other one to have a look at is the total distance. So measure from here to here. In this case, there's 4 boxes. So this is 160, which definitely meets the 110. So basically, if you have more than 3 boxes, small boxes that is, then you have left atrial enlargement. Now the reason why you get this M shape is if you have to think about it, the SA node is in the right side, okay? And you have to travel from the right to the left. And as the left enlarges, of course that's going to increase the delay from traveling from right to left, which leads to this prolonging. So these peaks effectively represent right atrial activation and then left atrial activation. Now let's move on to T-wave inversion and ST changes. So there's 3 things I want you to remember. T-wave inversion generally related to ischemia. ST changes, think infarction and some sort of injury going on. Q waves, necrosis, there's dead tissue. So generally there's 3 types of T-wave inversion really, or 3 types that you'll commonly see. The first one is ischemia, so you get a deeply symmetrical inverted T wave. Remember, it's deep if it's more than 5 millimeters. Now, left ventricular hypertrophy and strain, they're pretty much the same. You'll see one or the other. They're both indicative of ventricular hypertrophy. So often you'll see this in the left-sided leads for left ventricular hypertrophy. This one is pretty much the same, except this is just slightly raised, so you get a sort of fishhook pattern. With digoxin, you get a fishhook pattern, a reverse tick, sort of like this. Now, ST changes. It's important to know how to measure ST. So the first thing to identify is the J point. The J point is where the QRS meets the ST segment, so it's over here. Now you want to find 60 to 80 milliseconds. Since 80 milliseconds is 2 small boxes, this is the easiest to use. So say it's there. Now you want to find the isoelectric line. Usually this is the TP segment. So it's this or this. And you find the difference between these 2. This is your ST change. Now if the rate is particularly quick, then you can use the PR segment. So from here to here, you can find the difference. Now you're probably wondering, why have I asked you to use 60 to 80 milliseconds after the J point to work it out? Well, the atria repolarize during the QRS complex. And if the rate is particularly fast, so if the patient is tachycardic, then this P wave repolarization, say it's here, it can infringe on this J point. So therefore, it can often lead to J point depression. So if you go 80 milliseconds after, you avoid this interference from atrial repolarization. And so that's why you should do J point plus 80 milliseconds. Really 60 to 80, but 80 is easier to see on the paper. Now let's work out why you actually get the ST changes. So over on the left we have a model of the heart, and each of these boxes represent the cells. Generally when the cells are not doing anything, so when they're resting, you get a negative state. So like here, this is the depolarized state. Now if all the cells are depolarized, there's no movement of any ions or anything. It's electrically silent. So we have an ST segment like this. Effectively you can call that our 0 point. There's no movement, so that's neutral. Now, if you have subendocardial ischemia, you impair the cell's ability to depolarize effectively. So these ones are going to be more positive compared to these ones. So these are normal. Okay, these are depolarized. The inside ones are not normal. So what happens is during the resting state, actually, the movement of charge is that way, and it's towards the lead. Yes, there are some that go backwards, so as this part of the heart is negative. There are some that go that way, but the majority is this way, towards the lead. So therefore, this is going to lead to an increase in the in whichever segment it's measuring. So since this bit was the isoelectric line, what happens is this gets pushed up because it sees a wave of depolarization towards it, so it pushes it up. So it appears as though you have ST depression, but really you have elevation of the isoelectric line. So ST depression. Now, if you have full thickness ischemia, then all the cells are impaired and all of them will be relatively positive. But you still have other normal parts of the heart. So you have these negative ones over here. So during the time when the heart should be resting and during the isoelectric period, okay, so this is, this segment over here, there's a movement of ions this way. And so the lead detects it as movement away from it. So therefore, the isoelectric segment is depressed on the ECG. And this looks like ST elevation. So it's not really ST elevation, it's more that the isoelectric point, so the isoelectric line has been depressed. So that's why you get ST elevation in a full thickness infarct and in what we call transmural infarct, and you have ST depression in subendocardial ischemia. Now also, if you cast your eye back to, so if you remember back to the T-wave inversion, and you remember this I told you was the left ventricle. Often you see this in left ventricular hypertrophy. Well, this downsloping ST segment is essentially chronic ischemia, because the heart has hypertrophy to the point where there's now ischemia on this side, so in the subendocardial region, and that's why you get this strain pattern. So now let's move on to assessing whether the ST changes are significant or not. So generally, in most leads, if it's more than 1 millimeters, it's significant. Remember, you have to have 2 or more leads. Okay. In V2 and V3, the criteria is a bit different. It's 1.5 millimeters for women or female, 2 millimeters for males over 40, and 2.5 millimeters for males under 40. ST depression, no matter the gender, no matter the age, is 0.5 millimeters. Remember, you should always have 2 leads and the leads should be anatomically similar. So for example, if it's V6 and lead 2, they're not the same. V6 is lateral and lead 2 is an inferior lead. So classification. So remember, 1 in AVL, these are your lateral leads, they're literally on the lateral side. 2, 3 in AVF, they're at the bottom, so these are the inferior leads. V1, V2 are the septal. V3, V4, anterior. And V5, V6 are the lateral leads. So now let's move on to Q waves and electrolyte changes. So what is a Q wave? So if you have a look, this is an infarcted area. This is necrotic. It's dead, electrically silent. So effectively, the lead, which you can imagine as a camera, is looking straight through it. So the wave of depolarization, when it looks at this segment, is going to be away from it. So therefore, you get a negative deflection, which we call a Q wave. Now, I've already told you about Q waves that are present normally. So if you remember, we have, so this is the septum, and in the septum the depolarization is this way. So therefore in V6 and V5 and AVL, you can get small Q waves. Okay, now how do we determine whether it's pathological? Well, in the septum, really it shouldn't take more than 20 or 30 milliseconds to depolarize. So 1, if it's more than 40 milliseconds in width, this is very good criteria for knowing it's pathological. 2, if it's more than 1/4 of the QRS complex, but this is the one to focus on, more than 40 milliseconds. This indicates a pathological Q wave. If you see a pathological Q wave, you know some sort of necrosis has happened. Now, electrolyte changes. So hyperkalemia, I think of the T wave as holding lots of potassium ions. So if you have hyperkalemia, the T wave becomes taller, so you have a tall tented T wave. So you also have an increase in the PR interval. Now hypokalemia, I pronounce it as hypokalemia to remind me that you get U waves. So you get significant U waves, and you get T wave flattening or inverted T waves alongside ST depression. You can get some PR changes, but the main important thing to focus on is ST depression with prominent U waves. Remember, U waves normally are seen when the heart rate is less than 60, and they represent the Purkinje fibers repolarizing. Calcium, they're both related by the QT interval. If the QT interval, which is measured from here to here, is short, think hypercalcemia. If it's long, think hypocalcemia. Now, something else of interest is at the start I mentioned about hyperacute T waves and early STEMIs. I mentioned at the start of the video about hyperacute T waves and early STEMIs, and this is a good place to explain why we actually find them. The normal T wave should be asymmetrical, and it should look something along these lines. So if we draw a point from the middle, this side should be shorter than this side. In a hyperacute T wave, it looks like this. So if we now draw that, this is symmetrical. Should have drawn that properly, but yes, this is symmetrical. And the reason why is, if you think about it, when you have a STEMI, you have ischemia. If you have ischemia, this impairs the sodium-potassium pumps. So this leads to a local hyperkalemia. So local hyperkalemia. And this leads to the tau tented T wave. The hyperacute T wave, which is symmetrical as compared to symmetrical and tall as compared to this asymmetrical T wave, which has a more gradual upslope than a downslope. Okay, so let's finish off with an ECG case to tie everything together. So we'll do rate, rhythm, axis, hypertrophy, and infarction. Okay, so let's start off with rate. So in this case, we'll start here and go to here. We can see that clearly there's 1, 2, 3. So the rate is 300 over 3. It's 100 beats per minute. That's the rate. Now let's have a look at the rhythm. So the rhythm, we start the P wave and we go to the Q. So in this case, we see that there's 3 small squares. Okay, so if you have a look from there to there, we have 1, 2, 3. Okay, 3 small squares. So therefore, we have 120 milliseconds for the PR interval. Okay, this is normal. QRS interval, let's go from here to here. I see about 2 small squares. So therefore, the QRS is 80 milliseconds. So the PR interval is normal, the QRS interval is normal. Remember, PR indicates a problem above the AV node, PR is at or above the AV node, QRS is below the AV node, so there's no significant problem so far. So we've done rate, rhythm. Now let's have a look at axis. So we need to go back to the original slide. So axis, lead 1 is negative, lead 2 is negative. So let's draw our little circle. So since lead 1 is negative, since it generally points this way, we're going to shade the opposite side. Now lead 2 points this way, but since lead 2 is also negative, we're going to shade the opposite side. And this is right axis deviation. So for axis, we have right axis deviation. So we've done rate, rhythm, axis. Now let's move on to hypertrophy. So immediately the first thing that should strike you is actually there's quite a large R wave in V1. So if we have a closer look, we see that the R wave in V1 is 2 large squares, which is 10 millimeters. This exceeds the R greater than 7 millimeter criteria. Next, we have a look at V6. In V6, the S is greater than R. So again, this has more evidence that this is right ventricular hypertrophy. So in terms of hypertrophy, we can say that there's probably evidence of right ventricular hypertrophy. So now let's look at the atrium. So I told you the best place to look is in lead 2. So in lead 2, if we have a look at, say, this one, so this one goes from here to sort of there. So this is 3 millimeters. So remember, if the P height is greater than 2.5, we have P pulmonale. So therefore, we also have right atrial enlargement. So we've done rate, rhythm, axis, hypertrophy. Now let's do infarction. So if we have a look here, we systematically go through the leads and we have a look at Q waves. So there's no Q waves, no Q waves, no Q. AVL, no, there's no Q wave. In fact, if you have a look, in AVL, there's a very slight uptick. In fact, it's more clear there. Slight uptick. A Q wave is the first negative deflection, so therefore there's no Q wave there. No Q wave there either. And we do the same for all of these. So none, and we keep going down. So there are no significant Q waves. Any ST changes. Now, if we have a look at lead 2, it's very difficult to tell. Okay, so for example, if we look here and here, there's not really any ST changes. Same here and here. So I'll draw the lines properly. There and there's no significant ST changes. If we have a look at lead 1, here to here, yeah, not really significant. Okay. Lead 2, so remember the J point is here. You go 2 squares, so to there, and this is the ST segment. So draw the line. Maybe a millimeter, you could say, but only a millimeter in lead 3, and lead 2, difficult to say, but I don't think lead 2 has any ST depression. So now let's have a look at the precordial leads. So in the precordial leads, if we go down here, we see that V6, there's no problems. V5, depending on where you look. So in V5, so that's the J point. We go to, this is where we're going to measure from. And if we have a look, now the TP segment is upsloping, so it's a bit difficult. So in this case, I'll use that. So again, maybe a millimeter. There to there, again, maybe a millimeter. V4, same findings. So a millimeter of ST elevation, V4, V5. Now let's have a look at T waves. Since we're on the precordial leads, we can we should start here. So T wave inversion V1. Now these ST segments are downsloping. In V2, T wave inversion, same in V3, same in V4. V5, 6, they're normal. Now let's have a look at these are the leads. So in lead 1, normal. In lead 2, inverted. Lead 3, inverted. AVL, normal. AVF, inverted. So really we have inverted T waves in the inferior leads and in the leads that are on the right side. So V1, 2, and 3. So now let's write down our findings. So rate is 100. For rhythm, we have no problems with the PR or QRS intervals. So the PR is 120, the QRS is 80, so no problems there. Rate rhythm, now let's have a look at axis. Axis, it's right axis deviation. So rate rhythm axis. Hypertrophy, we have right ventricular hypertrophy and we have right atrial enlargement. So rate rhythm axis hypertrophy. Infarction. There's no Q waves. There's ST elevation V4, V5, very minimal, and there's ST depression only in lead 3. Sorry. So again, I'd probably say that's not significant. So what is the overall picture? So maybe they might have an ACS. Technically they have some ST elevation V4, V5, very, very, very subtle. But it's a 30-year-old male, and if they have no symptoms, then all the findings are explained by the right ventricular hypertrophy. So this ECG is characteristic of right ventricular hypertrophy, and there's 3 things that are in support of it. So you have the right atrial enlargement, which you'd expect if they have right ventricular hypertrophy. Eventually, you will get the atrial enlargement. Second, they have right axis deviation. Usually more than 110. This is definitely more than 110. And thirdly, they have T-wave inversion with a downsloping downsloping ST segments. For example, up here in lead 1, in V1, and this is further evidence that it's right ventricular hypertrophy because they have T-wave inversion in all the right places. So this is right ventricular hypertrophy. Now there's one more thing that I'd like to bring your attention to, and this is a very subtle finding. So in V1, if you have a look, there are actually very small R waves. So if I look at here, this is an RSR pattern, very subtle RSR pattern. In fact, it's most clear here. If we have a look at V6, see that there are wide slurred S waves. So S waves I normally consider anything more than 40 milliseconds, I'd say, is wide. So if you, particularly if you have a look at that one, so that is wide there and it's a deep S wave. Now if you have a look at lead 1, same thing, there's an S wave, AVL, S wave. So what we see, in fact, if we go back, what we see is the criteria for right bundle branch block, but the QRS is less than 120. So therefore we'll call this an incomplete right bundle branch block. So this is a very subtle finding, but I thought it's interesting to point out. So that's the end of the session. Thank you very much for listening. I hope I've shown you why having a systematic approach can show you so many things in the ECG. So happy ECG reading. I will be publishing some videos on more ECG walkthroughs, so please subscribe if you want to see those. Thank you.